Hi, everyone, and welcome to another ISPEC Talk. Joining us today is Dr. Milton Wainberg, Professor of Clinical Psychiatry at Columbia University and the New York State Psychiatric Institute, and one of the leading figures in global mental health implementation science. Dr. Weinberg directs the NIMH-funded Global Mental Health Implementation Science Postdoc Fellowship at Columbia, as well as an international implementation research training program in Portuguese-speaking African countries. He also serves as medical director of the Columbia University HIV Mental Health Training Project. Across his career, Dr. Weinberg has led federally funded implementation research in the United States, Sub-Saharan Africa, and South America, focusing on scalable and sustainable interventions that close the gap between research and practice. His work spans HIV prevention and treatment, mental health and substance use disorders, stigma, task shifting, cultural adaptation of evidence-based interventions, and large-scale workforce and capacity building initiatives. I don't think that's enough. I think you need to add more to that list, just saying. His career exemplifies how evidence-informed interventions can be adapted, disseminated, and sustained across diverse and resource-limited settings, a core focus of our mission here at ISPEC. Over the next 15 minutes, we'll explore what it takes to implement mental health and HIV-related interventions in complex systems, the lessons his work offers for scaling evidence-based practices globally, and how we move from research to real-world impact. Milton, thanks for joining us.
Thank you very much for inviting me. That's too long to say to, but shorten it up next time.
Okay, but there's a lot that our listeners should know about you, and I already shortened it. It was longer. Okay, so you worked in many different countries and many different health systems. What do you see as the absolute core implementation challenge, the number one issue that people need to focus on when implementing evidence-based health interventions?
I would say that, I always tell my mentees, there's three words that I want you to remember: sustainability, sustainability, and sustainability. Any effort that you do that you're not thinking of sustainability from the get-go, it's wasted because you pilot things, you do things, and then you don't know how you're gonna keep them going. So any of the projects that I try to do, I always involve community and policymakers as much as possible. So when we're done with the study and with the project and there's no more funding, it can continue. So most of my projects, I don't pay salaries. It has to be by people that are already in the system. I pay for training and capacity building and trainer of trainers to make sure that there's continuity. Because otherwise, which is what has happened dramatically in many, many, many scale studies, that, there's money, they do it, there's no money, they're gone. And that's very sad, very pitiful, and terrible for the people that are receiving the care that suddenly are not getting anything.
I wonder if that's ever been quantified, the sustainability issue,
It
because
has. There's actually there have been meta-analyses that look at things that are scale, and people look at acceptability, feasibility.
right,
Very, very few look at true adoption and true sustainability and sustainment. Like less than, I don't remember the percentage, but it's pitiful what's been
right.
done, because actually implementation science is a very young science, as you know. It hasn't been here for a while, and in many ways, NIH was not investing ever in implementation science. It was more in creating science, but who cares about how it gets to the real life? And now they care.
Right. So then does that mean that many of your interventions themselves are low cost? Maybe tell us a bit about some of your main interventions within mental health.
So, the reason why I have so much in what you said about me is because I started as a clinician and I realized that we were not providing proper care, that people were waiting and then they were leaving even before they would almost get anything. So I came from the real world to ask the research world to take care of the real world. And the real world is not one disorder at a time. It's multiple disorders, multiple issues. So that's why I'm comprehensive from that perspective. That's number one. Number two, I want to make sure that we take care of a continuity of care. So it's always embedded on something that can make sure that we address the whole presentation. So people with, for example, mild issues, moderate, and severe, and to make sure that, because I do task shifting, because there are not enough providers in the world to take care of what we need. And now in Israel, it's even more complicated, of course, Before October 7, people were waiting 6 months to get in care. And by the way, once they're in care, half of them after 3 sessions are gone, which means we don't do a good job. And this is data from the ministry, not my own data. The same thing happens here in the US. Between sessions 3 and 6, half of them are gone. So we're doing a terrible job on keeping
What,
them and
sorry,
taking
what,
them.
when you say gone, meaning they could just give up treatment?
Yep.
And then
And the
do
ones that
they,
stay are not necessarily the people who need it the most. It's the
and then,
people,
but do they
don't work.
reappear, let's say 6 months later, a year later, or
Oh,
what?
yeah, yeah. It can be a revolving door,
Mhm.
but they wait to start. They start and then they leave. And the people that stay are not necessarily the people that need the most. Those are people that can come regularly, they don't work, or they don't have children, or they have support system that allows them to come more regularly. It's really made for a private practice model within the public health model. And by the way, it's not that there's dramatic evidence that the private practice long-term model it's actually efficacious and effective. It's just what we've been doing for 400 years. And people are not going to be very happy that I said that and you recorded it, but that's okay. I don't mind.
It's
And
not just
that's
that we
one of the,
recorded it, it's going to be the opening on the, when we put it on
I
LinkedIn.
love
You know
it.
that, right?
That's why I love talking to you. But I have to tell you, you ask also one some of the barriers. The barriers is that change is difficult. And the people who have been doing one thing want to continue doing that. At the same time, they're afraid of the parnusa, right? I'm going to be able to make money. And they are not aware in many ways that there's so many people that need care that they could train and supervise people with lower levels of training, which can do a phenomenal job. There are multiple studies all over the world that even high school graduates and even elementary school graduates can do the work because in sub-Saharan Africa is done by people who finish elementary school and they're community health workers and they do HIV, TB, they do everything. And somehow they do a good job. Mental health specialists need to learn that our role should be training, supervising, and taking care of people who really need mental health specialists. It's like you're not going to call a plastic surgeon for a little cut in your arm. You're going to call the plastic surgeon when it's something in your face that you need to make sure, et cetera, et cetera. So that's one of the biggest problems. It's societies, associations, and policymakers that many times come from that group that considers, what's being done as the appropriate and rigorous care. It is. And I didn't say it very loud just in case. Yeah, it's complicated. Did I
Okay, so
answer your question?
yes, yes, but that actually brings me to my next question. So you mentioned already twice this concept of task shifting. So first, we're going to define it for our listeners that don't know what task shifting is. But after you define it, so it's a huge, that could be a huge solution. It could be an incredible and effective solution for all, our shortages in human resources, et cetera. So what do you see? We could talk about the barriers. I think we could
Forever.
all say them without even studying them, but what conditions, what facilitators need to be in place for this to actually work and people to buy in? So let's first define it, and then if you could just,
So task shifting is when you train, the task shifting and task sharing. There's a combination. It's when you train somebody who's not a specialist. It could be either a lay professional or it could be somebody who is within the health system but doesn't do mental health to be trained properly and supervise. And this is the key issue. It's not just about training, you do it. It's about maintaining the supervision. So the care for people with mild to moderate problems can be taken care of by either lay people well trained or other health professionals within the system that are well trained. Historically, when that happens, the system of supervision and rigor, it's not been done properly. So in these studies that show something, if you let go of what you put together for the study, then there's no maintenance, there's no sustainability. The way that I have taken care of that, because I saw these mistakes throughout the AIDS epidemic in sub-Saharan Africa, is making sure that we use very well put together digital tools that maintain the rigor, that guide the provider with what they need to do. And it's not just that they need to invent what they need to do. Every training for us has to have 3 cases under supervision to make sure that you know what you're doing and you continue super. So there's an element of keeping the rigor that has not been done previously that is incredibly important to maintain. And now with AI, we're thinking already of even better ways to do this that are not yet completely studied. For me, AI is here. We cannot if we don't work on with it, it's gonna step over us. For the time being, there's AI that can work for self-help. I would only recommend that for people that don't have disorders. I think of the complementary elements of that and not supplementary them of them. And we are envisioning how to bring AI with a provider being there and not just on your own. So we make sure that we take care of things. Uh, so those are for me incredibly important elements to maintain the rigor. Besides, the want in and buy in from policymakers and other professionals, which in a way makes them feel, oh, okay, there's going to be some rigor. And these tools can help you know what each person is doing all the time. So you can even do proactive supervision. You don't have to wait for the person to tell you this happened, et cetera, et cetera. It's more that you have a platform that provides you constant evaluation of what's taking place from clinical outcomes, from services outcomes. You saw Milton today. When is the next time that you saw Milton, and what happens there? And implementation. Are we really taking care of the community? And that's another element that we're doing terrible. Our system of care is not a public health system of care. We wait for people to come to us. Our next step has to be, which is complicated everywhere, including in Israel, how do we do community and health systems together? And the social services, education, and health ministries have to figure out a way to work together. Municipalities may give us an answer. I don't know. I'm trying because I'm trying to do a lot of this in Israel. But there's definitely need to be a continuity, and we need to go out. Community health workers in the poorest countries go to people's homes. And actually, for example, the adherence to antiretroviral is very good in those countries because these people go, HIV antiretrovirals, I'm talking about HIV illness, because people are going constantly there. And you don't wait for people to come to you. And here in high-income countries, we wait for people to show, and when people show they're sicker than when they are, if you go to their places in a regular basis to do, my dog is coming to say hi.
To join the
So,
podcast. There's always a
yes,
first for everything.
he wants to be caressed. So that's another element that I think we need to move, to mobilize, especially mental health. Mental health is a little bit more complicated than other illnesses in other situations. Why? Because in other situations, sometimes it's about taking a medication and adherence to medication, which is important and difficult. For us, there's also the issue that you don't do one session. You do 4, 8, 12, and people think that only very, very well-trained psychologists can do that, which is beautiful when they can, but there's no need. So that's an element of the implementation of mental health that it takes much longer. The percentage of science of mental health that gets integrated into the real world is much smaller than other scientific knowledge. It's low to begin with because implementation science was not considered science for many years. And now that it is, you see that mental health takes longer because there are longer interventions. It's not taking a pill or doing a procedure, et cetera, et cetera. But because you guys are interested in policymakers, we need to I always include them from day one. The first work in Mozambique, I did it with the Ministry of Health. Here in New York, when I presented the work to the state of New York, who's funding my work here, I said to them two things. Great if you want to give me the money, and they were giving me money. I don't want the money if we're not thinking of what happens afterwards, and you need to change policies. There has to be a policy that these people will get reimbursed, because otherwise my grant is paying for salaries that it's not sustainable. And we had done don't tell anybody, but I did a little bit of work prior to that.
We're recording, but I won't tell anyone.
I know, don't tell anybody. I decided to plan a strategy of infiltrating within the system to understand what they want and see who could be a champion. So we did qualitative interviews with several people in New York State, trying to figure out what they think and presenting to them the idea of task shifting and presenting to them what's there and they were thinking, oh, so this sounds like it's something that we could do. And then we asked, what are the barriers? So when we went to organize doing this, we already had champions within the system that were very eager to implement what we were talking about because they had an opportunity to think about it in qualitative interviews that we were asking them, let's talk about the future of mental health in New York State. So that's one way of doing it if they're not informed, because people sometimes are not informed and you want them to be informed so they can make, evidence-informed decisions for policies.
Okay. So you touched on a lot of my questions here that I had from before, but so now I'm going to do a rapid fire of some questions. It's just rapid answers. So you mentioned
Go
how
for it.
mental health implementation science is different because the interventions are longer term than than in any other field per se in health. What else is different between implementation science within mental health and other fields?
It's about changing sometimes behaviors that are very chronically part of your life, or changing relationships that are very much in your life. So if you want to, for example, interpersonal therapy, you want to look at relationships and figure out what relationship works better and how to do that. That doesn't happen in 2.5 seconds. That
Yeah.
requires, but it can be done in 4 sessions. So it's not like it will take forever. But if
It
we're
also doesn't
dedicated,
happen in other fields, meaning that's,
there,
cancer
of
specialists are
course,
not looking at
when
that.
in other fields, when you have stigma, that's an issue that requires work, right? If people are stigmatized within their families, within their system, again, it's about community relationships and interpersonal relationships. So whenever is a context that it's complicated, it's harder. In mental health, you need the context to be supportive. Uh, for other things, you don't need as much that, it's something about you're making a decision. Also, for example, in HIV prevention, we used to make the joke, that to make a decision about using condoms, there wasn't, when there was no PrEP and other medications, the things that you can do. It's like you need two to tango, right? It's not just you who makes the decision. The other person has to be in agreement, and people don't know how to do it. So it's communication. So there's some things that to implement them, you need a little bit more than, this is a medication, you take it one time and you're fine, or an injection once a month, or a procedure that you implement with a system that it's eager to do more, versus these more changing behaviors, changing context, changing ways of thinking, and addressing symptoms. Also, psychiatric symptoms take a little longer to be taken care of. And sometimes you need to look at functioning and not just symptoms, because not all symptoms have to go away, and you want to. So there's some peculiarities about mental health and behavioral health that require more time to be done. Eh, and it's also, as I mentioned a little bit before, it depends on your environment. It's more connected to the people in your life. There are other things that you can make decisions on your own about what you're doing. You go to the gynecologist and a pap smear and this and that. It's you with you, whereas other things you require the environment to either be part or not be part at all, not to interfere, and how to handle that.
Okay,
And as you
so
know,
yes,
stigma of mental illness is also another element, right?
right. However, I'd say hopefully over the last 20 years, it's people are willing to talk about it more now than let's say 20 years ago. There's still stigma. I'm not saying no, but
I,
it's a
I, I have, I
world
have
of
to
a
tell you,
difference
you're
than
you're absolutely right, but the
that age
turning
ago.
point was COVID.
Really, I would
Because
think even before that. I remember at certain convocation ceremonies and people would start talking about their brother, the keynote would speak about their brother that had mental illness and no one had spoken about it before. And it was so,
no, no, of course that there have been some incipient little things, but the
right,
transformative happened with COVID. Suddenly people realize that mental health issues are important.
right,
In grants that were available, in the way of thinking, even HIV that had been dealing with mental health, they were not investing on it. And with COVID, there was an investment. Why? Because that could also interfere with adherence to care.
right,
But so with COVID, the understanding that we all need wellness and mental health was very important, because everybody was scared to death and everybody was anxious, and functioning was, and the whole system was like, what do we do with this? So suddenly mental health is important. So that was a pivoting time. And also when you're able to show that you can take care of things, it's much easier to talk about it than when you can't take care
Right.
of things.
Okay, so quick answer. You mentioned high resource versus low resource settings. You mentioned one difference that in the low resource, the provider goes to the person's house. We're in high resource, we wait for them to come to our offices. Are there one or two other major differences within your work? Because you've worked in those in many different settings that you see high versus low resource, the differences?
Well, the richer the place, the more infrastructure there is, and the more barriers there are to try to figure out what to do because there are too many chefs in the kitchen. You can have one small kitchen in a low income country where you're talking to everybody that will be involved in one conversation. Like when I arrived in Mozambique, there were 14 psychiatrists and 125 psychologists working in the system. In the first 2 days, I met like with
Oh, yeah.
40% of them, and they were involved in the system. When I do it in New York State, there's mental health, there's substance abuse, there's education, there's in Israel the same way. You have infrastructure that in a way can be reached to take care, but can be very obtrusive in the ability to make changes because everybody is protecting themselves. Another element is also science. I always want to make sure that we look at ourselves and what are we not doing properly. Academia in many places is about number of papers and number of grants, which means silos, which means competition, which means we don't care about the community. So somehow, if you if you do 20 papers on data analysis, you get promoted. But if you do interventions that take 4 years to happen and they're complicated, you may not get promoted. So, and the competition is so bad. So, for example, in HIV, because there was such an amazing difficulty, a terrible difficulty, on how we're going to treat the illness, the people who were doing medication HIV development decided to work together to be able to come up with solutions together. Very seldom that happens. And in mental health, everybody wants their intervention, the this and the that, as if there's no ability to. So the narcissism, did I say that out loud, of academia and the difficulty of looking at community work as part of what should be your advancement and your promotion. I actually was in a meeting with 4 deans the other day with 20 people. We're talking about working with community. And at the end, I said exactly this. I have 4 deans here. Can you guys look at changing promotion so it's not just about papers and grants and doing community work? And one of them said, Amen. So good, they're thinking about it. Because it's very important for us to transform the mind of those that are creating science to think already of implementation. And to do that, you need to work together because otherwise, it's competition. It's like businesses competing and not public health system working together.
Okay, so we usually end asking, what's one principle you would leave our students and our listeners with, but I think it might be the word sustainability. So I'm going to end with a different question, which is looking ahead, what do you see as the next major frontier in mental health implementation science work?
Well, number one, I want all your students who are young, energetic, with a brain that is much smarter than yours and mine, because they know things that you and I don't know, to try to invest in working on this because they can have public health impact. And I don't mean just mental health, because I know that it's a plethora of things. So the fact that you have these students that are interested in policy and implementation science, I love it. Number one. Number two, so guys, I haven't met you, but I love you already. Hopefully, I'll meet you in person one day. The other is truly how do I believe in community, and I mean community where we work and the community of us who can work together, and definitely start thinking a little bit more ahead. We need to use digital tools to maintain rigor, digital tools to measure across time, and AI to figure out how do we complement and improve what we do. And there are amazing people in Israel because you have people coming from the army that come from the areas of intelligence. They need to work with scientists and not on their own in doing startups to make sure that it's connected with science and not just I'm brilliant and I can do it, because most of the startups die because they don't have an expert really working with them. So I say, I don't know if I've answered your question, but these for me are very important elements to really move it
No,
forward.
you
But
have.
it's community.
Yeah.
And the other one is, I always believe, you ask about how do I work with different places. I actually go in, I listen, I consider and I pretend that I know nothing so I can try to absorb more of what's really happening. And then I can think with them. And the idea is to, okay, what options do we have? It's not, I know this and let's do this. I know too many interventions, which I love, and I let people determine what interventions to use based on their needs, their context, their culture, which is fascinating because then you see things, it's not just about what you think. It's so boring to do the same thing over and over again. So there's an energy of being adaptive to the context and the culture to be able to understand better what to do.
Okay. So, students, listeners, now you could see why I'm a huge fan of Milton. He's so dynamic. He definitely doesn't have an ego, which is it's always a pleasure to speak to people and work with people that, don't have an ego, are willing to learn, are willing to listen. So thank you so much for your time. And I apologize to my students. We went way over time, but I think it was worth it. Students, listeners, I think it was way worth it. So
Well,
thank
maybe
you.
the way to punish me for that, quote unquote, punish is the next time I go to Israel, I make sure that I meet them.
Oh, amazing. I can't guarantee you'll meet all our listeners, but you'll meet the ones that sit at ISPEC. How's that? Amazing.
Okay.
Thank you.
Thank you.